The opinions and statements made by the guests of the Success in Practice podcast are their own, and I do not endorse or accept responsibility for their positions. Any information given by myself or the guests is educational in intention and not to be taken as medical advice. If you choose to act on the content involved in the podcast, you do so at your own risk. Welcome everyone today to the Success in Practice podcast. I'm joined today by Matthew Harris. Matt is an osteopath currently operating and practicing at Everything's Connected Progressive Osteopathy in Melbourne, Victoria. He's been a registered osteopath since 2004, having first completed a diploma in remedial therapy and then attending and graduating from Victoria University in 2003. Early in his career, he was able to travel and teach in the UK at the British School of Osteopathy. He eventually met Gary Gray, who had an impact on his biomechanical understanding. Gary is from the Gray Institute. He attended a course with Gary at the Gray Institute in the US, where he learned about functional movement. Matt also studied classical osteopathy while in the UK, and upon his return, he combined his knowledge to help patients with their conditions. He currently works in private practice, is also a clinic tutor for half a day per week, and is also an athletics coach. Matt, welcome to the podcast, mate. Thanks for joining us.
Thanks, Sammy.
I know it's late, mate. I appreciate your time, mate. So, look, where I'd like to go today is to kind of I want to chat to you about some of the additional learning that you've completed post university, and see how that's really influenced you. And I'd like to take on how you view osteopathy in the context of what you've learned and how you personally apply it. We talk about principles a lot, and we talk about how they can get applied in everyday practice. So I'd like to get your views on that and how you personally apply those principles, and also some of the extra learning that you've done. You currently operate a clinic, so maybe we can talk about some of the challenges in current times and your views on osteopathic education and the fruits of that, given that you're a tutor, you're a clinical tutor. Mate, given your interest in classical osteopathy, maybe we can discuss how those concepts are being handled by the profession at the moment, and some of the side effects of maybe abandoning a classical approach, or at least understand the classical concepts of osteopathy. Mate, are you happy with that? I know there's a lot to unpack there. Is there anything that you want to kind of go down? We might go down some rabbit holes, but that's fine with me.
No, I'm happy to start wherever you would like to start. I can tell you about like my major influences, if you like, first, and then we can go into the...
Yeah, we'll discuss that. So that's you've led me into the first question, so thank you. Mate, you grew up with a sporting background and some health challenges. Tell us about how they affected your desire to learn more about the body.
Well, I was a sickly kid, suffered asthma. Pretty much every cold and flu that you could get was in and out of hospital. And I was probably like that for, I would say, maybe my whole, well into my early teens. And then it wasn't actually until I started to make some serious changes with my diet that I got my asthma under control, and that really directed me more towards that sort of, I guess, that natural health sort of field. And sort of things went from there. I was also like a keen basketballer. Did damage my ACL, and that made me interested in manual therapy, that sort of thing. And so it was like a bit of I was always leaning towards some sort of natural therapy. I just didn't know what I was going to basically move into. And at the time, osteopathy wasn't really on my radar initially. I just didn't even know what it was, to be honest. And so I looked into things like naturopathy, physiotherapy, and I didn't really like physio. And I had to have physio on my knee, and I didn't really enjoy the experience of it. And then, because I was kind of like, I was kind of left in a world where I didn't really know what I properly wanted to do. My high school grades weren't that great, and so I ended up doing remedial therapies, which was a 2-year course at that time at Australian College of Natural Medicine. And there's at the time Peter Lim, who was an osteopath. I don't know if you know him, but he was teaching, as was Gary Fryer, within that remedial therapies course. And so Peter actually treated my knee and did a fantastic job on it. And then I was like, that's it. That's what I want to do. I wanted to be an osteopath.
You were hooked.
Hook, line, and sinker.
Yeah, great. So tell us about some of your early influences then. I guess being at Victoria University, or even early on in your career, who really influenced you early on, and what were your, who kind of put your thoughts together?
So I think I was at Victoria University at probably the luckiest time. I was within that first, maybe there was like 3 years that existed before me, maybe 2 years even. And so the lecturers were like Peter Gibbons, Phil T, and Cynthia Tucker. Maddie Holmes at the time was like a fifth-year student who was just tutoring us. So they basically really formed the foundation for me at that point in time. Cynthia was a really strong influence. She was obviously quite aggressive with her thoughts around osteopathy, as was Peter Gibbons. So they set the foundations for me. I also had John Pitcher. He was one of my clinic tutors. They were all like instrumental in my early thoughts around osteopathy, I suppose. I actually went to work when I graduated. I went to work for Peter sorry, my brain's just
with John.
John Pitcher. Spent a couple of years with him. Yeah, so that was fantastic. Those times.
Yeah, right. And then so you started at Victoria University, and you've just told us about some of that experience, and you said that you were fairly fortunate to be in that lucky group. You mentioned obviously some of the people that taught you guys, and I'm assuming that's why you thought you were fairly lucky, because of some of the tutors that you had. What do you think happened after that? Like, what, do you feel like there was, had things changed, or, why do you feel like that was a lucky generation versus maybe the future?
I think it was a really lucky generation. I think at that point in time, the lecturers were still able to get away with things that they couldn't get away with today. Some of them, right. Sometimes it would be considered probably abuse today. Some of the things that would happen. But to get through that course at that point in time, you really had to be dedicated. Like it was really, really tough. And the Peter Gibbons and Cynthia Tucker, they had no mercy. Like I can remember, like they used to just pile on the students if they didn't like, like, they might not like what the student was wearing, and you'd be in all sorts of trouble. Yeah, and then just over time, the universities have become, it's become easier and easier to pass. Like, back then, our final exam was a CP5, which was you had to treat 2 patients off the street and then 2 return patients. And you were tested on your osteopathic ability. That doesn't even happen anymore. Like there is no, within the university now, there is no full examination of a case history from start to finish. Like it. Yeah, right. I don't know. Have you seen what the universities do now, where they have?
Mate, I'm not aware, and I'm learning a lot more through the podcast and just talking to people. I've had a look at some of the curriculum at both Victoria University and RMIT. It's just hard to get. I think it's better that we talk to people who are in the know and people who are there, and they've, I'm thinking of getting some recent graduates from both universities on the podcast and asking about their experience. And so I don't have inside knowledge, but that's the whole purpose of having a chat to you. And I'm asking these questions I don't want to kind of shit on new graduates, you know what I mean? Like it's not That's not my aim, but I think there's a real gap there. My personal opinion is there's a real gap. I see graduates. I've been doing it for over 20 years, and I've got graduates coming to Sydney, and I see a massive knowledge gap. I've got a current recent Victoria University student, and he would say, I talked to him about osteopathic principles. Mate, you're just moving somatic dysfunction out of the way. You're just getting it out of the way so the body can heal, and it's just there's two principles at play there that you really need to know about. And he'd look at me and say, we weren't taught that.
Yeah. What's the somatic dysfunction?
I can't say anything bad to him because it's not his fault. It's not. And so whenever I talk to people like yourself, and you mention the same thing, I've got to make a point of it, because I think we're letting some people down. These young kids are paying good money for education. They're coming out with $100,000 HECS debt, and they're not being taught what is meant to be taught. It's like, imagine you go and sign up for accounting and they teach you how to be a carpenter. It's like, it doesn't make sense. So, I'd love to have someone like Gary Fryer on the podcast, or someone who's in charge over at RMIT, and let them, state their case. Because what we're seeing is not aligned with, I think, what the profession needs. I think Melbourne's kind of getting away with it a little bit because there's such a high amount of graduates coming through, and so it kind of levels out. With certain people, there's a certain level of person, like a person has a certain level of mastery to themselves. There are people that will just level up. If you put them in this course, they'll do really well. If you put them out on the footy field, they'll do really well. If you put them, on a job site in construction, they'll do really well. And some of those people are in osteopathy, and they're just going to do well no matter where you put them. And so we will get some graduates that are pretty good, but I think the chasm between the really good ones and the ones that are struggling is getting wider and wider.
I agree.
That's my opinion, but I could be wrong, and I'd love to talk to people who can tell me that I'm incorrect. So.
No, you're bang on. Look, most of the students, most of my final year students couldn't tell you who AT Still was.
Right.
Yeah. So it's like, it's come a lot, like in the last, I don't know how many years, maybe. So I came back in 2014 and started at the uni again, I think in that year, or maybe it was the year earlier, and it was already in a pretty strong downward slide then, especially compared to where I'd come from, because I've just come back from the UK, and I was at the BSO, so that was really noticeable, that change within the Australian osteopathy. I think I 100% agree with you. There's always going to be good students, that's for sure, and there's some great students that are coming out this year. I don't feel as if that they're ever going. It will take a lot to make them osteopaths. How's that sound?
Yeah, right.
The fundamentals within the course have changed. It's not so like the whereas osteopathy used to be principle based, it's no longer now. It's more at the knees of the evidence base.
Right.
And that's I think that's from my perspective.
I'll get to that. I'll get to that then in one of the next questions.
Cool.
All right, mate. Look, I'll ask you about some of the challenges in education a little bit later, but I want to go back and speak about your time in the UK. What was that time like for you? I think from what you told me, you headed over there and you took up a position at the British School of Osteopathy. Given your experience over in the UK, can you maybe compare and contrast osteopathy here versus what's going on in the UK? And what were some of the challenges for you in either work or in education?
Well, that's a good question. So I actually went over there because I wanted to become a better osteopath. I still felt after my 5 years at VU and then working for John that I wasn't practicing the principles the way I wanted to practice the principles, or I thought they could be practiced. And
Flesh
so
that out for me a little bit. Tell me why. Like what was going on then that you felt like did you feel like you were just kind of, rub and crack kind of thing and you didn't really think about what was going on? Like what was going on there?
I was trying to not be rub and crack, but I was probably being rub and crack, if that makes sense. Yeah. So, I had all these good ideas in my mind about the body being a whole, all this sort of thing, but not really knowing how to put together the pieces of what was interrelated, what wasn't interrelated. Um, Good ways of dealing with somatic dysfunctions, besides manipulating it and maybe foraminal gapping. So.
Yeah.
Yeah, so I wanted to go and know if there was more and understand more, and so I basically, like I said, I went to the BSO, I tutored, but I also visited some of the more famous osteopaths while I had the chance to be there, like Hartman and that sort of thing, just to see how they work and see if I get a better understanding. Yeah, and so that's kind of what led me on my journey. And I actually met an osteopath, Deborah Bakovska, who she really stimulated my mind, and I liked the way that she worked, and she was kind enough to help grow me for a little while until I decided to move on to some other things. And as for at the BSO, well, the BSO was similar in the clinic setup to what VU was when I was a student. It was not the same, but similar. Obviously, they were much more. I shouldn't say obviously. They were much more articulatory in their techniques. So there was slight differences in that respect, but the ideas were similar. The way the way that the clinic was set up at that point in time was the same. Was nice. They had because it was a little bit of a bigger university. They had 4 tutors to a clinic room, a clinic group, which was probably about 20 students. And they had the really nice thing was it was at that point in time the tutors were of all ages. Like some of the practitioners have been working 50 years.
Yeah,
and
right.
So when you see that sort of expertise, and mixed with the younger tutors, so you've got that switching of knowledge. It was quite impressive, I thought, at that point in time.
And so, at that time, did you then? Is that where you kind of went and did a bit more study in terms of classical osteopathy?
Yeah, so I went down to Dorking and did the classical osteopathy course for a year. I was also studying the grey stuff at roughly the same time. And I was really looking for like the classical as it's taught down in Dorking is that was taught by Wernham. So that was a lot around the body adjustment. But what was really lovely was they were very big on old school principles, old school texts. So there was a lot more principles added to my toolbox.
So explain that out to me a little bit and to the listeners. I mean, to me, osteopathy is osteopathy. And so when you say classical osteopathy, as opposed to what else, I'm not really sure. Yeah. But can you explain that to us so we understand what you mean by classical osteopathy?
Yeah. So there's obviously the UK is an interesting place. When I say classical osteopathy, so Wernham, there was a I don't know what year it occurred, but at a particular point, there was a fight for who was going to be principal of the BSO, and it went one way, and Wernham basically disagreed, and so he took the school down and opened up his own school out in the middle of Dorking. Now, and then they work off a thing called the body adjustment, which is kind of like, it's a pattern that they run over the body. So it's a sequence that they run through, but depending on what they find in the sequence changes how they do their articulations and that sort of thing. Does that make sense? It's kind of hard to explain, but yeah. So I went down and studied with them. It informed me in lots of ways. It gave me some good direction for texts that were excellent to read, and it gave me, like I said, more principles to add to my toolbox. I don't use that style well, I sometimes use that style of approach, but I don't use it the way that they would want me to use it. How's that sound? Like
Yeah, no, I get it.
it's just a thing in
I
my
get it.
box.
Yeah, it seems like it's a system of kind of treatment rather than a like the principles of osteopathy. I think really are left open on purpose, and I think the more you maybe form it into a system, the harder it is to kind of apply it to every single patient that comes through your door. So I get why you wouldn't do that.
Yeah, 100%. And I like what
Yeah,
you've said there, because like the principles are like, for me, they're just things to help give me direction with the patient that's in front of me. That's like, I guess it's for me, they're like a little cheat sheet of like, okay, what haven't I thought of here? Um, and not it's yeah, and that's what I think the students are missing today. It's another thing I think the students are missing today is that osteopathy is dealing in the grey, not black and white, and that's
yeah,
the
yeah,
problem.
yeah. You're right, and that's the thing with especially with evidence-based medicine. Like I had an interesting conversation with Nick Lucas a few weeks back, and he said something interesting. He said, "Look, with the evidence-based medicine, it's the best average. You know,
Absolutely.
that's the whole thing that's going on there. It's like when we do a randomized controlled trial, we find out what the best average is." And I'm like, and he was like, "Look, sometimes you don't want average. Sometimes you want better than average, and you need better than average." And that's, I think osteopaths play an important role there because you're kind of like you're at the front lines of pushing the boundaries of when people just aren't getting better. You need to figure out something to do. I mean, you can't just if someone doesn't fit into the evidence, well, what do? We can't just leave them alone and have them suffer in pain. And so an
Absolutely.
osteopath will go and use their principles to kind of come about something, and if they can help somebody, great. And if they can help 10 people, even better. If they can help 100, great. If they can help 1,000, well, that then can turn into another trial. So that's the beauty of it. And I think evidence-based medicine and osteopathy, they don't have to collide. And this is the problem, is that universities see that if we teach one, we can't teach the other. So yeah, it's interesting what you've done over there in the UK, mate, and it's good that it's a good example that you've actually taken it on yourself to kind of go and find out some more. That's a really good way of kind of trying to level up your game. What does your clinical week look like now? Tell us what kind of volume of patients do you see, and what types of conditions are you treating? Are you more of a generalist that kind of applies what you know? Tell us what you do and how you operate as an osteopath.
Okay. So I treat. I'm treating 6 days a week. They're not not all full days. Most of them are like today's Tuesday, is why my brain's a little bit scattered. Today's a full day, but every other day is a half day. I normally see. Can you hear me? Oh, just dropped out for a second there. Sorry.
Yeah, that happens. Like I said, I'll get that on editing.
Cool. So my list, I run a 45-minute list with an hour for new patients.
Okay.
Yeah, and pretty much that's my week. So per week, I'm going to see around about 45 patients a week.
Okay. And do you niche down into certain patients? Do you have a preference into what kind of conditions you like to see? Are you somebody that's a generalist? How do you operate?
So my clientele it's a mix. I see a lot of geriatrics, a lot of post-surgical rehab. I also do see quite a few athletes. So it depends on the week. I don't have very. I mean, my clinic's in Camberwell in Melbourne. I don't treat very many office workers. Because it's just not the area. It's just not the area. But I'm happy to treat pretty much most things that come into the clinic. I don't treat kids below a certain age. Like 7 years of age will be the youngest, 6, 7, unless it's like a favor for somebody.
Okay. Tell us about your time at the Gray Institute. What did you learn there?
Okay, so the Gray Institute, probably that was what really changed. It changed the way I practice. For me, it enabled me to become the osteopath that I wanted to be. Like the osteopathic principles just come out in that work. How's that sound? So like the Gray Institute's about functional biomechanics, but it teaches you how to look at function and then understand what rotations of the bones should be doing in space given that particular function. And so it enables you to tie together how a foot will affect a low back or how a big toe can affect a neck. And you can see it. You can see it in action. So it was just a way for me to get into osteopathy the way I wanted to, if that makes sense.
Yeah, no, it definitely does make sense. I think there's more to be learned there, and I think we're missing out on a big chunk of knowledge in terms of understanding proper biomechanics. I had a conversation. I think it's the second episode in the podcast series with John Abdullah, and one of John's mentors back in the day was Steve Porter. And Steve Porter was an engineer, and he became an osteopath. He was one of the first students of Ivan Wellerman and Peter Cash, who set up osteopathy here in New South Wales. And Steve was an engineer, and he really applied a lot of force vectors and mechanics to the body. And John was explaining how he really learnt how to use forces and vectors and understand how long it takes for the body before it kind of fails under load. And John was my primary mentor. Like, I learnt under John, and I studied under John, and I eventually took over John's clinic here in Sydney. So he kind of relayed that information on to me. So I practice in that way. I'm very mechanical in the way that I practice. And I think there's an opportunity there, and there's definitely a lot of things that we can learn from engineering and force application and how the body kind of reacts to force vectors that we're just missing out on. And it ends up, when you don't know that stuff, you're kind of just looking at movement, but you don't know the details of it, So
Absolutely. Yeah. And you don't know how to affect in a way that's safe.
Yeah, no, I mean, affecting it comes back down to your treatment, and I guess that's something you would have learned over at the Gray Institute too, in terms of maybe exercise and all that kind of stuff, and I'll discuss that with you in a minute. Explain to us how you go about incorporating some of the concepts that you've learned in terms of functional movement into your treatments. Like, tell us about that. Hello, everyone. I'd like to take a quick moment to thank everyone for watching and listening to the podcast. If you have received value from this episode, the kindest thing you can do for me is to like, share, follow, and subscribe to the channel on whichever platform that you are listening on. If any of the conversations have resonated with you and you feel that I can help elevate your practice, you can find me at successinpractice.net. That is, the Success in Practice program can be found at successinpractice.net. The Success in Practice program is the signature program that takes a practitioner who may be struggling with retaining patients. They may not be certain about building effective treatment strategies, and they may feel somewhat anxious and doubtful about what they are going to do with a patient. And they are not really accelerating in the real world of private practice. It takes this practitioner and it turns their careers right around to the point where the patients have an effective diagnosis and a real treatment plan that they can take home. Patients are happy to book in multiple sessions with you, and they are confident about your abilities. And more importantly, you now have direction and are confident about your own abilities. The program streamlines how you operate as a practitioner. Guys, you should have been taught this at university, but you weren't. You may have been practicing for the last few years thinking there has to be a better way. There has to be a more effective way of engaging with patients and getting them results. Well, there is. And this is what the program delivers. Go to successinpractice.net and check out the options available to you. See where I can help you easily grow your patient list and finally earn the rewarding income that you deserve. For all the information on how you can reach me personally, check out the show notes. Also in the show notes, you'll find a link to the chat transcripts from these podcasts. These are valuable and a wealth of information. I really hope that you're enjoying the podcast. Guys, leave a comment if there's any questions on this episode, and please, don't forget to like, share, follow, and subscribe to the channel. Now, back to the show.
So I guess just as an easy way to to
How does it play out? Like, how does it play out in real life?
Yeah, so let's say I've got when I take a case history, I'll be asking about the task that's problematic for the individual. Does it hurt to walk? Or, does it hurt to lift? And then we'll break down the biomechanics of that task to help treat the person, basically. So you might come in, hurts you to walk, so I'll have you walk back and forth. I'll ask you to walk in various different ways to see what's moving, what isn't moving. And then that's basically where the basis of the treatment comes from.
Right, and do you aim to reproduce their pain with certain, either testing or like if they get pain on walking, do you try to reproduce their pain with walking? Is that the aim, or is it just to look at their movement?
No, it's more to look at them. So the pain will inform me, but I'm not one of the principles I work with, which is going to go. Probably we could have a good debate with some of the people who are interested in the pain sciences. But one of the things that we talk that's very important with the work that I do is that it doesn't hurt when we're actually doing what we're doing. Like I don't pain is a driver, and I don't want it corrupting the biomechanics. So I'm trying to avoid it. So while it might show up in my assessment, it's not the thing that I'm actually overly concerned with.
Okay.
I'm more concerned with the reactions the body's going through.
Okay. And when you then put a treatment together, is most of your treatment, I mean, you're doing hands-on physical kind of passive care and then you're applying some active care, or what? How does it work out?
So it's one and the same for me. So we have it will depend. So sometimes I'll use a treatment table, not as often as probably most people. I have a thing called a true stretch cage, which is I can put people in upright positions, and then I can do the mobilizations upright and standing in the task specific position.
Yeah, right. And then when you go to
I'm still using my METs. I'm still doing the Gray Institute has a thing called FMR, which is basically just a manual movement assisted.
Yeah.
But I'll use all my techniques still. I'll still use my counter strain. I'll still use my MET. All that sort of stuff. Just upright.
And so when you then go to put some, maybe once you want to give somebody something to take away with them, how do you go about constructing their rehab plan or their exercise prescription?
Yep. So I work in a way that's not like a typical rehab. So I'm not giving deadlifts. I'm not giving. That's not what I'm doing. I'm working on giving them more efficient movement. And so whatever position I get them into, I'll try and create and mimic that in a doorway, or I'll mimic it using a staircase or a chair at home, or whatever it is that they have to help create that mobilization and that movement.
And so do you view that particular process of you maybe being a bit more active in your treatments, is that you trying to remove somatic dysfunction, or is that you just trying to avoid pain?
I love it. Great question, but a bit of both. So I want to avoid pain and allow them to move freely, but at the same time, I'm still interested in what is the spinal segments, what's the freedom between the spinal segments. It's a mixture of. It's not just like I'm not exercising them.
Yeah.
How's that sound?
Well, what I'm really trying to get to is that do you consider the exercise as the actual treatment for their condition, or is the exercise something that adds on once they've improved their movement, once you've helped them improve their somatic dysfunction, their facilitation, once you've done your work, is the exercise then something to kind of get them improved and moving better, or is it the actual treatment? Is it the actual medicine?
Yes, it's both. It's both. So the test is the exercise, and the exercise is the test. And so the way I go about getting that spine to move, I'll be using my hands, but I want to set it up in a way that when they get home, that I've created enough freedom of motion that they can achieve the same thing without me, or at least have a little bit of a go without me.
Right. And so are you finding that people come to you with things that give them pain in everyday life, in everyday movement, like, getting out of bed, getting off a chair, trying to bend over and put their shoes and socks on in the morning, these kinds of things.
That's exactly it. So that's a good example. Like today, I think one of my patients, the low back pain was only present while they're in bed. So everything we did was lying down. It would have looked a little bit more like a standard osteopathic treatment with movement around that, a little bit of extra movement alongside of it. But then I also had an arthritic knee, and so that was all upright, and and that was all performed. All the treatment was around thoracic mobilization, standing to help offload that knee when they were walking.
Yeah, right. Okay, interesting. Look, probably not the way that a lot of people that listening would treat who are experienced. You're definitely doing something that's a little bit different out there. Not the way that I would treat in terms, or the way that I would think about my particular views on rehab is that I give rehab once the patient is moving better already from what I'm doing for them. So it's a little bit different, but that's good. I enjoy having these conversations because it kind of makes me think about stuff too.
Yeah, let me run this back again a little bit because I'll try and create a little bit of a better understanding. So I don't do rehab in a sense of you're never going to see a clamp. You're never going to see. It's just.
Yeah, I get that. You wouldn't say that with me either.
Yeah. So it's like what I'm going to do is I'm going to position the body and So I run through. So like again, you were talking about before principles and that sort of stuff. So I'm trying to work with the reservoir of compensation. So I know if let's say the low back is under duress, then I'm pretty much. It'll be the last place I'm going to go to try and treat the person in front of me. I'm going to look at what the hips are doing. I'm going to look at what the thoracics are doing and how they're talking to that low back.
Right.
And by giving them the motions that, your type 1s and your type 2s and that sort of stuff, offloading that low back so the person you're treating it without them even know you're getting at it.
Right. And like I said, you're doing that passively and actively, right?
Yeah, so that would be done. What I would say is kind of seamlessly. So let's say I've got someone standing, and I'm passive. I'll move from a passive articulation into rotation to making it more them assisting to me resisting. So I'm moving through different.
Yeah, I get that. I get that.
And it's happening like this.
Yeah. No, I get that, and that makes sense. Yeah, I get that. Yeah. That's fine. Yeah. That makes sense. So it's very interesting, and like I said, it kind of gives me food for thought as well. Look, mate, you've currently before I move on to anything else, you've attended a lot of courses specifically in terms of human movement and understanding human movement, and I guess let's talk a bit about rehabilitation. Let's talk a bit about post-treatment, like, you've done your treatment. Now maybe you want to improve someone's strength, or you want to get them, more resilient to the stresses that might overcome them and give them pain. How do you feel rehab should be taught in light of osteopathic thought, like in light of osteopathic philosophy and principles? Are we teaching rehab in the correct way? I don't know what they're doing at university at the moment. I don't know from what I see, not much, but I could be wrong.
So this is a tough question because it's not the way I would do it. So I wouldn't teach the way the unis teach it. Like what you're doing, you've gone on to do some further study, and I understand that. But I think having a baseline knowledge, at least, of rehabilitation principles, progressive overload, understanding how to get something stronger, just basic stuff, add 2.5 kilos a week, I'm not sure what's being taught. I'm not sure. And I know that there's a lot of postgrad stuff in terms of strength and conditioning, but it's such a massive part of what we do on a daily basis is that this should be included in the curriculum. And a lot of osteopathic clinics out there, like doing like clinical Pilates and, stuff that you would just adapt to in 6 weeks, and then you have to move on. Yes. Yeah.
So how do you feel about that? Like, how do you feel about
Well,
rehabilitation, exercise prescription? How's it all being given?
okay. Yeah. So this is, I think, yeah, I get your, I like your point. So, like, one of the problems is that we're no longer dealing with principles, right? So, if we went back to dealing with principles, we could put rehabilitation in really easily because it's all about principles, and you don't even have to show an exercise. But what's happening in the universities now is that they're not doing rehab. They're showing exercises, and then they're either
It's a recipe
down,
approach.
downgrading it or upgrading it.
Yeah,
Here,
right.
so they're taught like here, do a bridge, or you can make that harder by do a bridge on one leg, or you can make that
Yeah,
easier by.
okay.
But there's
Yeah,
no
right.
there's no going through specific adaptation to impose demands. Yep, and so that
Yeah,
people
yeah,
have there's nothing. So it's almost like the physiology. I think if I had the ability to go into the uni and do whatever I wanted, I would teach like you were talking about there, just general principles of how to create strain on the organism because really that's what we're
yeah,
talking about.
yeah, 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 yeah.
Yeah,
Yeah,
and
definitely. Yeah,
yeah, because we see like we see lots of craziness, like in terms of like you've either got people who just know how to put weight on something, so they just increase weight over time. Well, that's great, fantastic, but there's a lot more to rehabilitation than just the one dimension of strength or whatever it
yeah,
is we want to discuss. And the osteo courses are bloody long, so we could get in there and we could do a bloody good job if we wanted if we
yeah.
wanted
You
to.
could. Yeah,
Do you know what I mean? It's like, yeah.
yeah,
Uh, so, so yeah, the difficulty is that from what I see in the universities and that sort of stuff, and this is all coming back to a similar sort of problem, right? They want guidelines. So you might look at the I don't know whatever the Canadian ankle guideline is, and it'll tell you how you should load
I,
and do whatever.
yeah, yeah, right.
But there's no
Protocols.
proof
I
of
want
that.
protocols. Yeah,
Correct. There's just no, and if I was the students these days, I would be so bloody confused. It isn't funny. So in one class, you're being taught an eccentric protocol for hamstring tendinopathy, but
yeah.
in the very next class, you're doing pain science, and none of that bloody stuff matters. It's
Yeah,
like it's
yeah,
like
right.
I'd be like, the students deserve to be slightly schizophrenic.
Yeah, well, oh, mate, it's I like that. I like that explanation. I think I see. I don't have an insight into that, and the fact that you're mentioning that really, it's an eye opener. And like I said, if I get a chance to have a conversation with some students in the near future, I'll be asking those questions. And segueing off to that, you currently have osteopaths working with you, and you've been exposed to the current quality of graduates. What do you think has been the catalyst for the change in the graduates? Like you were kind of about to start on that earlier. You said that back in your day, that your lecturers didn't really have they weren't shackled. They could kind of say what they wanted to say. And what's really changed? Like what stopped a first year university tutor, doing a tutorial with 20 osteopaths or 30 osteopaths in that class and saying, hey, let's look at the talus and see how that affects the pelvic movement. What's to stop that from happening?
Well, the uni stopped that happening now.
Sorry, say that again. I missed that.
The uni just doesn't allow that anymore.
The university just doesn't allow it, right? Okay.
Yeah, it's like because it's a little bit like you're talking about the protocols. They're trying to produce a student that is, I don't know what the word would be, but they want a uniform student across the board. Yeah.
Right. So they're trying to make osteopaths, physios, chiros, EPs kind of all do the same thing.
Correct. And this is the thing that annoys me the most, right? Because I like it may sound like my osteopathy is not similar to a lot of your the listeners, but I'm a hardcore osteopath. Like I don't go in there and tutor to make money. Like that, there's no money in there for me. That I do that. That's part of my passion. Is like I love osteopathy. This is like I'm 20 years experience. I know you're a little bit longer, but I'm like still working my ass off doing the job, and I want to do the job. I don't want to have a clinic that's making millions of dollars. I want to get out there and I want to help as many people as I can with osteopathy.
So why can't you say it? I mean, you're a clinic tutor. Why can't you say those things at university? I mean, do you not say those things at university when you're kind of doing your job?
So right now at the university, what's happened is they no longer allow tutors to put in input that not all students will be able to receive. So, like, if I'm just teaching one shoot group and I'm not teaching all the other students, I can't add in. So I don't teach them any of the stuff that I do. I try and challenge their minds. I'm not showing them new things. Whereas in the past, that you would have 4 tutors and everyone would show a different way of doing things. And I think that's what grows a mind, and that's what grows an osteopathic brain. But that's what they've removed from, or part of what they've removed from the universities. The other thing that they've done is that they're in trying to make a homogeneous osteopath, they've changed the examinations so that they're all fair and equal. So in that respect, they never allow someone to get assessed on their ability to treat a patient. Like there's at no point in time would a lecturer get to sit down with a student and examine them on a full osteopathic consultation. It just doesn't happen anymore.
Okay.
And how can that be when you never examine them on the thing they're going to be? Like, I'm constantly having to go about this at uni. It makes no sense. Like, can you imagine, like, I don't know, a doctor never doing surgery if you examine them on everything else?
Yeah, it doesn't make sense. And I guess when they come into your clinical practice to take on positions, you're pulling out your hair going, like, there's so much mentoring you have to do as a principal. And I mean, you put some time aside for mentoring, but geez, if I'm going to hold your hand through every single person, and there needs to be another kind of, maybe a separate course, a separate diploma, a separate something. I mean, I've set up the Success in Practice program exactly for that point, is to teach osteopaths how to be classical osteopaths, if you want to call it that way. How to use foundations, how to use principles in everyday life. They're not just arbitrary religious things in the sky. You can actually use the principles to formulate treatment. You can actually use principles to formulate diagnosis. And then it tells you exactly what you need to do, when you need to do it, how frequently you need to do it. And those principles are the foundation of everything that we do. And obviously you need to have a certain amount of understanding of diagnostic procedures and then treatment, and understand variables and understand how to put treatment plans together. But they're all processes that you can teach students. And that should be really the way that we teach. We should be teaching people how to get other people better, not how to just give out protocols that may hit the mark or may not hit the mark. And that's what we call the average practice. That's average practice. That's evidence-based practice is average practice.
Yep.
Right? And so I guess that's why we're graduating average graduates.
Absolutely. And look, it goes.
Yeah. So look,
the problem is deeper than that. Like, if we're allowed just to have a bitch and moan, I might as well get on my high horse.
Mate, go for it.
The other thing that is happening these days is that osteopathy is a skill, yeah, and this is happening not just at the universities here, but I know it's also happening at the BSO. They're removing more matured clinicians from the university process. Yeah, so the tutors are becoming, I think Ben McChesney and I are the oldest tutors at Victoria University now, yeah? And we're only 20 years, yeah? Like, that's when we're nothing. For me, I'm like in my midlife of my osteopathic life. The old boys are pushed out as if that skill set isn't highly valuable. Yeah. Yeah, and part of that I think is so the unis can maintain some sort of control. yeah, I think that's what I think that's what it's about. But it's
So what's the role of the head of the program? I mean, I'm not sure who's the head of the program at RMIT.
So I'm at VU. So Gary
I
Fryer
know you're
is
at VU. So I know that's Gary Fryer out there. So
yeah
what's his role in all of this? I mean, he's an osteopath, as far as I know. Gary's an osteopath like yourself and myself, and I'm sure he practices osteopathy. And I guess how do you reconcile kind of being an osteopath and then not being able to actually teach osteopathy in an osteopathy course? Like, it doesn't make sense. It's like I feel like I'm running a Seinfeld skit here. You know what I mean? Like it's it doesn't make sense.
One of the things I think happens is because I mean, Gary's a lovely guy. He doesn't practice though anymore.
I'm sure he did though. Like, he's not, I mean, he did practice. He knows what osteopathy is about.
Yeah, but I think what happens is they get stuck in the ecology of the school environment, and then they think that becomes the thing. Does that make sense? Like,
okay.
It's all great to have a PhD. That's fantastic, but as an osteopath, you're asking before, am I a generalist and what do I do? Well, I treat what comes through the door. Like, yes, patients would start to get to know, like, the elderly patients like me, so they tell other elderly patients, and now I've got more geriatric population. But I do my thing, and I try and do it the best I can. If it's an elite athlete, I'm going to do the best I can for the elite athlete. I don't know if I'm making sense or not, but like...
No, you're making sense. It's not like you're going to get somebody come through your door and you're going to say, I'm going to give you the real medicine. It's
correct.
Like, you're giving everybody your best. I get that. And you're giving everybody osteopathy. And it's kind of like, if you've seen that movie, The Matrix, like at the end of it, when Neo just sees everything in like ones and zeros, and I guess that's what you want to get to. You just want to see everything in ones and zeros and try to kind of manipulate the variables and use your principles kind of no matter who you're seeing. So I get that bit, and I totally agree with you. I understand what you're saying.
And then at the uni, though, they get obsessed with these damn PhDs, right? So they're moving away from the thing osteopathy is. Like, they become, like, don't get me wrong, I know they're very smart people, but a PhD means you know a lot about one thing and stuff all about everything else.
You need someone with a PhD in osteopathy.
Do you get what I mean? Like, sorry, you just dropped out again for a second there.
Yeah, that's all right. We'll fix that up with editing. Matt, look, I really appreciate you taking the time to do this, and I guess I want to explore that a lot more because I've like I said, I've set up this course, Success in Practice, to really help people, to help new graduates, and I'm not really sure what the level of competency that's coming out, but you've kind of fleshed it out for us a little bit, and I appreciate that. How do you? Let's say you're in charge of. Where are we going? Are we going wrong also at a professional level in terms of the association? Does the association have a role to play? Because I mean that's the bit that represents us as osteopaths, I guess. And so I can't just go to the university and knock on the door and say, hey, what are you guys doing? This is terrible. But I guess, as a professional association, I mean, can they knock on the door and say, look, we're not getting osteopaths here. We're Osteopathy Australia, but all the graduates that are coming out, are not to the level that we'd like it to be. Is there a role for the professional association to play? And then moving on from that, how would you fix it? What do you think realistically fix it? Like, not just go in there and just sack everyone that's not towing the line, I guess. But like, what are some options available for people? What are some options available for us as a profession to kind of remedy this? I mean, because otherwise we're not going to end up having an identity in the next 20 years.
Yeah, that's a really good question. I don't have the answers, and what I will say is, look, the university is full of great people. Maybe the product is not great, but I wouldn't go in and sack everybody, because I think there's some really great minds there. But so just coming back in there, what I don't know is this: so osteopathy in my experience, we're a small profession and we live outside of the realms of Medicare, really. Yeah. And there seems to have been this, for I don't know how long, there's this push to make us this homogenized thing so that somehow we can get into hospitals and do whatever it is. That's not where we belong. It's not where we should be. It's not where the direction of osteopathy should go. When I started working as an osteopath way back when, anyone who came to see me had maybe seen they'd seen a chiro, maybe they'd seen a physio. They'd never seen an osteopath, and that if they had seen an osteopath, it was always quite a stressful thing because you're like, oh damn, someone's got to them first that knows what they're doing. Yeah. Now though, like I have patients come in and they've seen 2 or 3 osteopaths, and I can tell you often what those osteopaths will have done to them without even just from the complaint that the patient has, yeah? And you're probably seeing the same thing, yeah? You're probably seeing
I see a little bit of it. I wouldn't see it as much as you because there's not as much saturation in the market of osteopaths here in Sydney as there is in Melbourne. So you've been seeing a lot more of it because there's more osteopaths there. So they might go through 2 or 3 osteopaths before they get to you. Hello everyone, just a quick break to give you some information on where to best find me. The first place is the private Facebook group called the Successful Practitioner Pathway. I've set up this private group as a place where practitioners can go and get tips and advice on how to best accelerate their practice and improve their clinical practice skills. The second place to find me is at successinpractice.net. That is where the Success in Practice signature program is housed. You can find more information about me and how I can best help you achieve success in your practice. So the 2 best places, the private Facebook group, the Successful Practitioner Pathway, and successinpractice.net. I will link to both those places in the show notes, so for more information, please see the show notes. Now, enjoy and back to the show.
This is and that would never used to happen. It just never used to happen, right? It's like, and it's not that because our numbers aren't that much. If you actually look at our growth, it hasn't changed that much in all that time either. We've kind of stayed the same. And right now, I think the dropout rate of new grads it's at an all-time high. Yeah, so like I think the average like maybe is 2 years now or something like that, right? So 2 years working as an osteopath now, who's to blame for that? Like that's got to be the unis. Like that's an unprepared student entering the workforce. Yeah. Now, the other thing I think obviously that's changed a little bit since is COVID changed things. I think my patient base in Melbourne changed significantly post just the way the anxiety levels here in Melbourne changed significantly. And so I understand there's going to be that little bit of pressure on the graduates to deal with that maybe I didn't have when I basically came out into the workforce and that sort of thing. But either way, they're still not prepared well enough if this is how long they're lasting. And you've got someone you do have to nurture them more now. That's just the way it is. Like even in my clinic, so my guys are like Shani's been with me for 10 years, but Nat and T is maybe 2 and 4, and they're definitely more work to don't get me wrong, my guys are brilliant osteopaths. They're hardworking. They're all about osteo. Like my clinic, we sit back after we finish at night and we have a drink and we discuss our patients, that sort of stuff. So they're keen and they want to be there, but they're not as well. The underneath training is not as good as it was. Not even as good as when it was Shani was going through uni. And so a lot of what we're doing now is teaching stuff that they should have known coming into the workforce.
Yeah. Look, I guess I'll probably have to disagree with you on one little point there when we say we got to blame the universities. Ultimately, we have to look inwards. Like, the universities are obviously they have an agenda, and they're not actually dishonest about their agenda. They're not saying to us that we want you to be osteopaths, but on the other side, they're not teaching osteopathy. They're telling us that, we want you to toe the line in terms of being physios, chiros, osteos, EPs. You all have to practice the same. We want you to learn protocols, and you're not allowed to teach principles that, that are arbitrary and kind of, old style religious stuff. And so the universities aren't really lying to us. They're doing what they want to do. It's us as a profession. We need to, anytime we've changed things, it's been osteopaths that have led the way, and no one's speaking up about this. No one's saying anything. There's people with loud voices online, and people with loud voices in the osteopathic community with good following, and they're not talking about it. That no one's really and when you do talk about it, like I put a post up about 2 months ago, and I shared it to the Osteopathy Australia member forum. I'm a member of Osteopathy Australia, and the lady that looked after the forum asked me to take it down because she felt like, or other osteopaths had complained because she thought that what I was saying in the post was that graduates aren't as good as they used to be. And what I was saying in the post is that graduates were being let down, and they're just not getting taught what they need to be taught to actually survive in real life private practice. So I wasn't saying anything incorrect or it was just my experience. But she said they'd had complaints from other osteopaths that said that they felt like that particular post was pretty much shitting on new graduates, and I wasn't trying to do that. It wasn't my intention, and so we had to take it down. So it's like, and that's the Professional Association's Facebook page. And so I go back to osteopaths. What are osteopaths doing to scream at the universities and say, listen, the level of graduates that are coming out, that they deserve that. Number one, they deserve better. The students deserve better. You've had many probably 18, 17-year-olds go through your clinic and go, I want to do osteopathy. I just had 2 last week. I want to do what you do. I want to do osteopathy. And so I'll say, look, go to Melbourne or go to Lismore, do it over there, and come back here and work, and we'll sort you out. Not a problem. But can you imagine then me sending them to a university and then coming back and saying, what'd you do, mate? I've spent $100,000. I'm not even an osteopath. I'm not doing what you do, Sammy. So it's not fair on them. And I guess, what are we doing as a profession? Well, what's the association doing? We see stuff about, I don't know, we just got advanced practice and all this kind of stuff, and I'm like, advanced practice, why don't you get the basics right? Why don't you help your new graduates actually come out as being osteopaths instead of worrying about advanced practice? So, that's just one little thing that I can kind of talk all day about. But and so, I think the association has a role to play there in terms of having a louder voice and speaking to universities. Now, they may be speaking to universities, but we don't know about it. There's no communication there. It's not like they're posting about it. And so, that's one case. They're probably scared. The association is probably scared to lose another course, So I get that bit. I get that anxiety. But there has to be a solution, either a placement type system where students can go and work in rural clinics where the clinicians or the people that own the clinics aren't shackled by university protocols. So there's that solution. The other solution is to have a separate course run and have that be part of your registration. Do the university course, and that could be just a straight out physiology and anatomy course. And then you have a separate course outside of the university structure that teaches you how to be an osteopath, and then you combine the two and off you go. And so there should be some solutions there, but we're not talking about it, and we're not talking about it now. And I'll tell you what, we're going to be talking about it in 15, 20 years' time. We won't be talking about it because we won't exist.
No. Well, that's the thing. Because the big push appears to me, like I said, I'm a tutor. I'm not really deep in the university. I'm not deep in the university to see what's actually going on. But what does appear to be the case is that the universities are moving towards a manual therapy, not multiple manual therapies. So
100%. Yeah.
And they really want this and I don't know that an association can stop that. Like, because the universities are. I mean, look at Victoria University. I know Gary Fryer resisted the block mode. Because you know what they do block mode at Victoria
I understand the
University.
block mode. Yeah.
Yeah, but the university, like, they just bulldozed over the top of him. That was like, if osteopathy wanted to stay, it was had to go block mode.
Yeah.
So, and how can you do block mode like as an osteopath, right? Let's take a student in their first year and say, we're going to do anatomy in the first 4 weeks. And by the way, you're going to need to know this again next year. Good luck.
Yeah. No, it doesn't make sense. But I guess, look, you're right in saying that the association may not have the power to ultimately stop that. But I mean, they should be at least saying something,
I agree.
And so, maybe they are. I don't know. I mean, I don't know. Maybe they are. If someone from the association wants to come on board to the podcast and tell me otherwise, happy to have anyone come on, any one of the board members, come on and have a chat about what's happening there. So happy to do that. And I guess another option, like I said, is to run a separate course alongside what's being taught at university. So that could be another option. So, but we have to do something, because the way we're going, it's just going to be homogenous. It's not. There won't be osteopaths and chiros and physios. It'll be something. You'll be just an APRA practitioner. They'll call you an APRA practitioner or something like that.
That is definitely the way the things are moving. Like, and I think that's even moving that way. It appears to me that even in the UK, it's moving that way. Now that the BSO's gone, and NUCO has now been bought up by the Chiropractic college. It's like, I don't know what the answer is to stop it. But I do know that I do feel as if part of the problem, like I was saying before, is that osteopathy stands slightly outside of where lots of osteopaths want us to be placed. Yeah. Like, I'm not. Yeah, and I think that's okay. I think that's for me. I'm happy. I'm happy with that. Like, I don't need to be like in a like I said, working in a NHS hospital ward and that sort of stuff. I have a place out in out in the public.
Mate, I had a conversation with Ann Cooper that was the first episode of the podcast, and I said to her, what do you think we're doing to kind of allow the university? And she said, well, we're too stuck on registration. And it was like, that's a radical idea. You know what I mean? Like, we have to go through university courses to get registered. And her opinion was like, well, why do we need to get registered? Like, what's the point? If they're going to if we're going to not be osteopaths, why would you get registered? You might as well not be registered and practice osteopathy. People will still come and see you because you do good work. People are still going to come and see you. The market's the market. They'll decide ultimately. And I guess that's a radical idea, but it makes sense the more you think about it, and the more you think about the way things are going. I guess that card should be on the table. But anyway, mate, we could probably talk about this all night, and we'll probably do a round two.
I will throw one more in there just before you go. The other thing, what else is missing now? This is going to sound bad, but the death of the guru. When I went to university, you knew the great osteopaths. And you had something to model yourself against that was impressive. That the new students don't have that at all.
Yeah, one of the things that I've mentioned before is that new graduates aren't very confident, and a part of the reason why they're not confident is because they haven't actually seen it work. And what gave us some confidence is that we saw people do it and it worked, and we go, hey, if they can do it, we can do it too. And then that gave us some confidence in the early years to kind of go out there and try it. And then, it works. Great. Let's do some more. And then off you go. You're kind of on your way. But if you're not seeing someone ahead of you doing what you want to be able to do, you're not going to have confidence in your abilities. It just doesn't work that way.
Exactly. Absolutely,
Yeah.
bang on, bang on.
Yeah.
And
So,
and and the last one is, and I know you've got to
no,
go.
I want to ask you another question, but keep going. That's fine.
So the other thing that happens when you're following the evidence base and you're doing it to these protocols instead of just using it as to inform yourself is that when things don't go well, you don't blame yourself. It's got nothing
Yeah.
to do with you. You followed the protocol, so
Yeah, right.
it's them. Yeah,
It's the
but
patient's fault.
it's a patient's fault. Yes, it's the
Yeah.
patient's fault. Yeah, and
Yeah. They didn't recover.
correct. I hear these things at the uni, and it's like, to take. Obviously, you don't have to take on full responsibility for everything that happens, but taking on the partial responsibility is what makes you a better osteopath. That
Yeah.
suffering when you don't have success is what helps drive you on the next patient, and
Yeah.
that's
Yeah.
it's
Yeah.
taken.
The more responsibility you take, then the more authority you'll earn. That's really
Absolutely,
key. The more responsibility you take in that treatment room for getting somebody better, the patient will then look to you with authority, and because you've taken on that responsibility. That's a hard thing to do. So look in the mirror and go, look, I got you. Give me 4 weeks on this, and we'll get you into a better place. All of a sudden, the
absolutely,
patient looks up and go, mate, I'm all in. So you'll get authority out of that. But if you don't know what you're doing, you can't just say those words and hope that it's going to come out of the sky. Mate, we've been talking a lot about some of the issues that we're facing at the moment, and it sounds pretty doom and gloom. What are you optimistic about in the near future in terms of osteopathy? What do you like about it?
well, I think, like you said before, so as I tutor, there's always that 10-15% that really want to go above and beyond. Like, like um, at my clinic on a Friday night, for those students who wanted to, we started doing just some clinical tutoring. Just offered it up to the final year students to trying to help get their systems exams doing a little bit better. Getting their hand skills up, and we offered it. So I offered it out maybe to, like I said, maybe 20 to 30 students, and 2 or 3 took it up. And those 2 or 3 are still, that was, what was that, maybe a year and a bit ago. They still come to my clinic once a month and, want to learn and talk and discuss the patients they've got now in practice. I think that's inspiring. Like those students who find a way to, they fall in love with osteopathy and they find a way
Yeah.
to continue to learn. And there's tons of them out there. You've just got to that's part of me going and tutoring. You've got to get in front of them.
Yeah, no, that's great. That's my thoughts exactly. I have had the pleasure and the privilege of mentoring probably a good, I reckon, 15 students and now practitioners over the last 20 something years of practice, and that's been the greatest joy, is to kind of see people go out and kind of build their own building. You've got a tall building and they come and they build a tall building right next to you. And I guess that's one of the joys, and I'm optimistic about the same thing. I just hope that we can, it's sad that we need to be the ones to do that rather than the actual course, because we should be taking them to the next step, not trying to actually fill that gap between what they're learning at university and what real life practice is actually like. We should be taking them past that and into the realms where they can actually really help people with complicated conditions and complex problems. That's where osteopathy really does its best practice. In the outliers.
Absolutely. And,
Yeah,
like the other thing is like, conversations like this. And, I have friends still in the UK, Chris Wilkes, he's working at the UCO and he's trying to make a difference. Deborah's working out at Sheffield University out there and she's trying to make a difference. There's osteos out there that are trying to pass on their version of what osteopathy is and who love osteopathy for, what it can provide to the patients. So I think all those things excite me. Like, I don't know where osteo is going to go. Like I was reading the other day that actually I was reading just today that AI, there's some AI physio in the NHS now or whatever, and,
Yeah.
that concerns me.
That's no surprise. AI just doing. I mean, if you just put a whole bunch of protocols in there, it's not going to.
Correct. Well, that's the thing that does. If I'm talking about my real fear, that's my fear, because if the universities are pushing towards that, then
what's the point?
That's correct. It's an easy thing for that. That can happen very easily, can't it?
Yeah, definitely. No, what's the point? You'll just get AI. They'll tell you what to do. Matt, mate, it's been great chatting to you tonight. How can people reach you?
My email address is matt@everythingsconnected.com.au. I've got a practice that's in Camberwell.
Yep.
Yeah, that's probably the easiest
They
way.
can search for you on Facebook and Matthew Harris, you'll come up.
Yeah. I think I've got an Instagram. We've got an Instagram thing. I don't really do any of that sort of stuff. Really, I'm just.
All right.
But I'm an old school osteopath, just wanting to practice.
Jump online, everyone. It's everythingsconnected.com.au. I'll link that in the show notes. Matt, it's been a pleasure, mate. Thank you for your openness. I know that you're a tutor, and I've spoken to a couple of others that do tutor, and they just don't want to talk about what you've talked about. They're and that's understandable. And so, thank you for your openness in conversation and your forthrightness and your honesty. I really appreciate that. We'll definitely do a round two, where we might go deep diving into some of the things that we talked about tonight. Is there anything else that you want to add before I say goodnight?
No, I will just say, look, like for everything I've said about Victoria University and that sort of stuff, it is a good institute. It's a good institution. It just needs to go back to, like, we have to understand our principles again. That's what, and I think if we can, a little bit like what you said before, if we can match the principles along with the evidence base, and then they're not the antithesis to each other. And I don't
my words exactly. They're not antithetical to each other. You can. I mean, philosophy is not. I mean, there's no n=1 in philosophy, right? Like, philosophy is a philosophy. It's not something that you then can go and test. And so. We're not talking about mathematics. We're talking about philosophy. We're talking about principles. And so I don't know why evidence-based medicine would be against that particular notion of osteopathic principles. So, and once students understand how to apply their principles, everything becomes so much easier. And so, and there is a way to learn that. It's not just like, here are the principles, go and put them into action. There's actually a way to learn it. And you can pick out strain patterns, you can pick out dysfunction, you can pick out pain, and you can break it down, and at each point you can go, this is the principle that's guiding what's going on here. This is the principle that's guiding what's going on there. Look at their recovery. This is the principle that's guiding what's going on there. And then you break it down that way. If you do that enough, students will pick up on it. They'll start to see the pattern. And then they'll just do it themselves,
Agreed.
Right.
And I think that's what got lost. That's what got lost, is that for a while it just became principles, and principles were taught as a subject away from the clinical side of osteopathy, and then eventually they just got pushed out.
Well, I know when we were taught over in the University of Western Sydney course here, we got taught principles early on. First year, first day, first hour, right? Was just principles, okay? And that kind of went on for the whole semester, even in the first year, and it permeated through everything that we did in second year and third year. But, really first year was where it got drilled into us. And then what happened? You went away and you went in a big circle and you studied all the other stuff that you need to know: anatomy, physiology, orthopedics, everything else that you needed to understand. And then you came back into a circle, and the last semester of fifth year, you were taught principles again, and then bang, they just go, okay, go out into the world and go and do what you got to do. And just everything was easy. It wasn't hard at all. And so, I guess I'd like to see that come back into university education. I don't think it's a big ask. And I guess if they're not willing to have it back, we need to find a solution as a profession for it. I've put out my solution. Like I said, I've got the Success in Practice program. I think that's a fantastic place for anyone listening that wants to learn about principles, how to put together diagnosis, how to put together treatment plans, treatments, how to communicate, how to everything, to do with private practice and real world practice can be found in that program. But anyway, that's a cheap plug there for the program. Mate, I'll let you go. I know it's getting late. Everybody, just want to thank Matt for joining us. Thank you, Matt. We'll do round 2, and I'll see you soon, buddy. Good talk.
Excellent. Fantastic.
All right. Cheers, man.